An incredible program so far. Thank you all for joining us. I'm Melina Cambizzi. I'm the Senior Vice President of Business Development and Strategic Marketing here at the Alliance. And we're going to finish our program today before cocktails. So I'm in between this and cocktails, I know. But we're going to finish with this incredible panel of both actual providers, folks that provide care, but also executives at companies that provide care in a different and an alternative way. I wrote down a note from Dr. Rick, who was wonderful, wasn't he? He said, actions to reduce healthcare costs. That was his very last slide. So this is what we're here to discuss today, actions to reduce healthcare costs. So we heard from him about the economy. I've heard some comments, maybe it's optimistic, we'll see. But I know that we're all feeling it today. We all feel the economy, we all feel what is happening to our workforces. So now we want to provide you with solutions to help reduce costs for both your organizations and also your employees. And we know that where we receive care has a huge impact on our employer's bottom line and also on our bottom line as well. This panel believes it so much that they've actually left the traditional healthcare system to do exactly that, to provide care in, I know Cheryl said multiple times, innovation, provide care in an innovative environment, in an innovative way. So let's just hear from them. And before we start with questions that we already have from our employers and our audience, I would like to introduce each and every one of you. And I hope that I know I will not do, I hope I can do a good job for you. So Dr. Sabina Singh, I'm starting from the beginning here of the room. Dr. Singh is a co-founder of Anovia Health. In fact, her partner in Anovia Health is here with us today. An independent, unaffiliated primary care company working with many self-funded employers to provide high-value, cost-effective healthcare and also to direct with steerage. Dr. Singh, before she joined Anovia, was with Belen for over 20 years. So she left, that's what we're talking about today. She left the traditional health system and now provides direct care to employees, patients, and employers. She's a strong advocate for innovation in medical care, and Dr. Singh has been a past participant in several Institute of Healthcare Improvement programs. I'm told that she's an avid bike rider. She enjoys our Wisconsin trails, and fun fact, she takes care of herself, so she hasn't fallen off her bike for the past 3 years. That is fantastic because I fall off every day. Following Dr. Singh, Dr. Wendy Molaska. Let me just first say, of course, family medicine physician for over 20 years as well, long history. As importantly, recently she was voted by her peers, and she is the president of the Wisconsin Medical Society. And so long experience, she has extensive also experience as a patient herself. So being from both sides of the stethoscope, what she has decided to do is open up her own direct primary care clinic. It's called Dedicated Family Care here in Pittsburgh, so not too far from here, as an alternative way of providing high quality comprehensive primary care to her patients at affordable rates. And now, as a business owner herself, Dr. Molaska is here today to provide a perspective on how direct primary care, you may call it DPC, can immediately provide cost benefits as well as other benefits to employers, also to patients. Let me just say that I'm honored to say that Dr. Molaska is my family's physician, and she's taking care of my family like it is her own family.
And that wasn't a HIPAA violation because she said it.
And I asked permission before I said it. I said it. Mr. Tom Henke, with ACOS MD, he's the Chief Growth Officer for ACOS MD, an experienced healthcare executive with deep digital healthcare management and managed care experience. I asked him, everybody's about 20 years. He said, oh, close to 30. So a long time in managed care, just some of the most notable positions: Senior VP and General Manager and Chief Innovation Officer at Medical Health Plans, In 2010, Tom left Medica to launch Quick Check Health, I think a little too early, right, for our
About
history
10 years,
here.
yeah.
Yes, an early virtual care startup. Later, he led national sales at both Amplifon and Medtronic. And today, Tom is a frequent speaker on topics including consumer-based healthcare, digital healthcare, care management, healthcare innovation, and value-based care. He also lives, fun fact, he lives in Las Vegas, Nevada. So he's joining us today from out way west. Bridget Krieger is the Chief Development Officer at .com Therapy, a leader in online pediatric therapy services, something that we so much need, pediatric therapy services. With a passion for clinical care and patient advocacy, Bridget started her career as a radiation therapist treating cancer patients and was part of only the second group in the country to become a board-certified patient advocate. Today, Bridget will share how teletherapy can work in a family ecosystem from both a provider and a patient and a parent perspective. Growing up in small rural town in Wisconsin, she knows firsthand the impact, the limitations that access limitations can have on family dynamics. Last but definitely not least, a friend and a partner, Kate Grohol, VP with Holista. I think you heard Cheryl, Holista 200 plus bundles, our recent provider affiliation. And I want to also mention that with some of these executives, some of these providers, some are directly affiliated with our network. They're contracted with the Alliance. Some have a strong relationship and strongly affiliated. So I'm sorry, I didn't mean to shortchange you here, Kate. Kate is known for transforming bundles into episodes of care that go well beyond aggregated services for a unit price. Her company, Holista, has taken bundles and constructed a risk management product that wraps around the bundles to close gaps in care, reducing risk and substantially improving outcomes. The model is the key to addressing total cost of care. Holista has bridged the chasm between healthcare delivery and healthcare finance in a single product. Holista has operationalized share accountability between providers, patients, and payers with warranties for all of the bundles. That is her stamp of approval in quality outcomes. The cost of care, the delivery of care, and the experience of receiving care are equally accounted in this model. So without further ado, we have several questions. Jennifer will be giving us questions from the virtual environment as well. I'm going to start with our good doctors, Dr. Singh and Dr. Molaska, but first, Dr. Singh. Why did you decide to step outside Bellin, step outside that traditional system and deliver care not only as an independent physician, as I just mentioned, but also in a direct relationship with patients and employers?
Well, of course, everyone talks about physician burnout. Not a pleasant topic, but it's there and it's real. And it's a fact of not being able to practice the way that we feel we're trained to practice, the way that we want to practice. And I think Wendy could share a lot of similar stories and examples of not having enough time, not being able to call a patient back when you want to, not getting them in your office when you want to. So all the issues with healthcare sort of come to a head in primary care because this is where you start. So it just became time for me to make a change. I tried to make a change internally. I was a physician executive with Bellin, trying to do all the right things to help our patients with the system, to help the system work better, to help our employees work better. And it still wasn't giving the results that we wanted. So that led to rethinking on how could we do this better? And one way to do it better is to have that direct relationship. That's what gives long-term results. That's what patients crave. That's what I wanted to be doing. So started in 2021, so not very old practice here. We wanted to be independent, so we could work with anybody. We can send patients anywhere, and wanted to be unaffiliated for that same reason. We want to have all the scope of services that could be available at cost-effective, high-quality providers. So that's what led to my initial change, and it has been an amazing process.
Dr. Molaska?
Pretty much very similar in that, yeah, burnout was a huge thing. As a primary care provider in a system, I kept hearing from my patients, hey doc, it takes 3 months to get an appointment with you. I have to see whoever's available. I'm told to go to the urgent care. And that wasn't the type of practice I wanted to provide. I'm a family practice physician. I want to spend time with my patients. I want to get to know them over time, get to know their whole family, and be able to do all of the stuff that I've been trained to do. And a lot of that has moved away, I think, from primary care in terms of, hey, if you have a bad knee and you need a steroid injection, you have to send them off to ortho. I'm trained to do that. Why can't I do it right in the clinic? And then part of it was my patient experience as well. So as a patient going through the system, having surgery and stuff, I would be able to go through my EOBs and figure out, the costs and the pricing and what my insurance covered and where my deductibles and copays and coinsurance was. And inevitably, there's always something wrong on them. And after one of my surgeries, I spent a year fighting the insurance company because two providers were trying to bill for the same procedure. And as a doctor, I know that you can't do that. But I started thinking, as a layperson, as an employee, as an individual, how do you know that? And even my husband, as he looked through the stuff, he's an intelligent guy, but he's like, I have no idea what any of this means. And he's not in medicine. So it's like, how as a layperson are you able to figure out what's covered by your insurance, what isn't, and how to get that cost-effective care? And then, as Melina had nicely mentioned, I'm president of the Wisconsin Medical Society, and one of my interests has always been in health disparities. And so knowing that there are a lot of patients out there who are not getting good quality care, it's not affordable, they're skipping care because of inaffordability and stuff. So really wanted to address these different things. And so, yeah, went into direct primary care and could not love it more. Get to spend all the time I want with my patients, get to see them when they need to be seen, get to establish those relationships, and just am really, really happy with the change that I've made.
Can I ask you, if a patient calls your clinic, who answers the phone?
Either myself or my nurse. So, and that was the fun thing yesterday. Again, we got just a cold call to the clinic asking, can I sign up to be a patient or whatever? And I answer the phone, hello, this is Dr. Malaska at Dedicated Family Care. And they're like, you're the doctor? I'm like, yeah. I was just trying to call to talk to somebody about maybe being a patient. I'm like, yeah, you got me. But you're the doctor. Yeah. So the fact that, yeah, it's my nurse or me that's going to be answering the phone just blows people's minds a lot of times.
Yeah. Tom, Bridget, and Kate, a little different, almost same question, but a little different. So you also did exactly that. I mean, I was teasing Tom before because he started in 2010. What was it, like 12 years, 14 years too early, right? Virtual care. What impact, positive or negative? So the question is to all three of you. I'll start with Tom. What impact, positive or negative, did you experience starting out in this kind of new environment outside, for you, Tom, outside managed care?
Yeah, it's a great question. Managed care has trained me kind of how the health systems interact and work with carriers, and I found that didn't work. Moving on to a startup environment and an environment where we're able to redesign completely from the ground up, we're able to address the problem directly and come up with new ideas and support and collaborate with others. We're not competitive. I mean, none of us could serve all of you in what we do. And so for me, being able to be part of innovations that matter versus innovations that drive price up is really, really important to me. One thing that you all have, you may not know it, but today you all have open access DPC for all of your employees today. So with the innovation that Melina led us to, we are now available to all of your members and we can start reaching out to them. But when we need help and have to send to someone, there's going to be times where it can't be virtual. We're 50 states, but we're not in the home today, and we're also not we don't have clinics. So that collaboration nature is just something that doesn't exist in my experience in the big health systems. We compete with each other. You probably don't know this, but if a provider came to me and said they wanted a pay increase, I had to always factor in the fact that if I told my members, which I by law had to do, that there was going to be a network disruption, it cost me $2 million to write that letter. So if I'm going to spend $2 million, the providers all knew they could get 1.999 before it was worth my time. So it's a very different business when you're actually tackling the problems directly and collaborating. And it's really, I'm telling you, it's very, very fun. There's a lot of good things coming for you guys. Bridget?
Yeah, so .com therapy has actually been around since 2015. So an established company pre-COVID. So I think some of the hurdles I think that I faced when I came into .com. My goal was really to take the services that we have been doing since 2015, serving K through 12 school districts, and how do we take those services and enter them into the healthcare space. So one was finding the strategy of what works for that, and then being a virtual only clinic kind of sometimes does have its hurdles when it comes to contracting, because it's a new way of doing things. We don't have a physical provider location, so sometimes the old kind of contracting processes kind of slow us down a bit. So that's one thing. But I think the Alliance actually was our first provider network provider group, and so from there we've been building, and it just takes a little bit of traction to show that we can do it. And so we're always very grateful to the Alliance for that.
And our contractors are right here in the front table, so they thank you for joining us. Yes. Kate, same question for you.
Yes. So I have been fortunate all along my career to be exposed to innovators and innovators that are focused on quality theory. That's my educational background, and I've tried to apply it to healthcare. And so I've been blessed with that, and primarily innovative physician partners. But I was in a health system. And so fighting, my biggest challenge was the inertia back to status quo. I bring up an idea, and as you mentioned, they just, nope. So to do good work, literally fought against the status quo. And through my travels, and people will say, well, are you on the provider side or are you on the payer side? I'm like, why are there sides? Why aren't we all working together? And so I'm fortunate enough to have folks that came to the table with me and said, well, you don't have to be in the status quo. You have innovators that are here to bring forward all of the ideas that you've been talking about. And there's all kinds of partners now that weren't around 10 years ago, but a lot has happened in the last 5 years to bring innovative partners into this space, providers. Holista, we partner with primary care to bring what I call a value-based supply chain. Direct primary care providers, when you do need specialty care, what are your options? Holista is that option. We have specialty care providers that get it. We don't contract for line items, fee-for-service contracts. We contract for folks that are going to do great work and address a particular condition and do it on a budget, essentially. So we wrap those bundles. I just described the bundle package of services. We wrap that around with care compliance and keeping that patient engaged in following best practice that their provider wants them to follow. And so we're decreasing risk for a poor outcome. So we've taken that bundle, now we've matched it with clinical care outcomes, best practice, and we work with that patient all along their care pathway to make sure they're compliant. We drive down risk.
I'm going to stay with you, if I may, because we have a lot of employers here. And one of the difficulties that employers have, I mean, we heard Cheryl saying 55 shoppable procedures, shoppable services. If we can steer for just these 55 shoppable services, we can save, I know our chief analyst is here, I'm going to say about 10%, and I don't think he's going to get upset with me, about 10% of the total, 10 to 12% total healthcare cost. So, but it's difficult to do that steerage. And I'm going to come back to our providers as well. But from your perspective, what advice would you give employers to encourage the use of these different models?
Mm-hmm. So having partners that understand the value-based supply chain and how to work together, not be duplicative, but to serve your employees and make this simple. Complexity is expensive and it's exhaustive. So when Holista is working with primary care providers and with organizations like the Alliance, we want to come together and make this a single point solution. Either that's plugging and playing with your solutions, but it should not be the patient having to navigate to 8 different vendors that the employer is having to navigate those individual vendor relationships. That's our lift to do in our partnership so that it's seamless, it's simplified, and it's a much better care experience, both financially as well as clinically, and just how they feel cared for all along the process. So we're here to do that lift so that the employers can encourage their employees what a much better experience this is, and that they should utilize it.
Bridget, same question for you.
Yeah, I think meeting your employees where care works for them. Obviously, .com Therapy is a telehealth organization, and when you have employees or caregivers that have neurodiverse children, their worlds are complex, and it is very hard to find providers. Wait lists are very long, and so just looking for alternatives and helping steer employees where maybe those providers that would be beneficial for their work scenarios, and that are lower costs. And even in your benefit design, I mean, therapy in the grand scheme of things is relatively low cost compared to ED visits or other issues that may come up. So helping have that kind of low cost option for families, I think really helps.
Tom?
This is a great question. I have a passion for you. You are why I left Medica. I was I had a really great job, but it wasn't fulfilling to pass along fee increases to hospitals and clinics and send you the bill. Didn't feel right, and I think you should be really aware of how powerful your voice is. What you have here is really special. I've been involved in a lot of coalitions around the country, and it's very difficult to get the density that you have and the ability to really have a loud voice. So I'd say number one, use your voice. The second thing, I had a friend of mine and I used to teach an MBA class once a year at St. Thomas University, and he was a physician. He reported to me, and it was a practicing physician, and he said, I was the bad guy, as the managed care guy. And he would say at one point, what people don't realize is I write for services that I do in my clinic for me and my nurse and my team. I bill about $400,000 to $500,000 a year for that work, but my pen writes $6 million worth of orders. So you should not care about primary care. You need more primary care. It's the only thing in healthcare we need more of. In fact, I would argue, it's a little bit of, we could debate this, but I would argue a fee-for-service managed care or primary care might be in your best interest, because you want the providers wanting your business and hiring fast to take more of your business. Because if the right providers are using their pen correctly, they're going to get the real money addressed. And then the third point I'd make, I think that's really sad, is that you may know this, you may not know this, but your patients don't pick their practice or the physicians very scientifically. It generally is, where do I live and who's close and who markets and sent me a brochure when I needed to get in, who could get me in. I mean, it's really simple stuff. But once they make that primary care decision, you may not know this, but they've made their referral pattern decision as well. They don't know it. So when they do get sick and they ask their physician, where should I go for my knee surgery? It goes to the mothership. It goes to the hospital that owns them, by and large. And so untangling that requires getting to DPC. DPC is, there's a Milliman study, if you want it, I'd be happy to send it to you. 24% reduction in inpatient admissions, 52% reduction in emergency room use, 5% outpatient surgery reduction, 12.5% overall claim cost reduction. That's what DPC can do. And if you can get your employees to use DPC that's not affiliated with systems, it'll last a long, long time. That savings will be there every single year, not just 1 year.
And to double back on that. So all the savings you just mentioned from DPC, now take that supply chain into the specialty care episodes.
Exactly.
Right.
We are a 55% reduction against the control group. And that is unit price only. Then add on to that, we've reduced unnecessary emergency room utilization by 50%. We've demonstrated a 30% reduction in preterm labor resulting in NICU babies. Huge. And we have a 98 net promoter score.
Yeah, definitely. That's where the money is. So yeah, definitely, Wendy and Sabina, let's talk about that $6 million pen. How do you do referrals?
Yeah. And so this is one of the interesting things, is that in the system, I'm referring within the system. But now that I'm outside the system, and this is actually about 3 months into my practice, I had this aha moment where I'm sitting there and trying to figure out where am I going to get the highest quality, lowest cost Holter monitor, a cardiology procedure done for a patient. And I'm putting in all this time and effort researching this and trying to figure this out. And all of a sudden I went, oh my God, because every January, every plan changes its formulary and I have to change all of my diabetics who are fine on these medications to different medications because the insurance company says I have to. And none of that directly benefits the patient. And so here I am spending at least as much time researching where to get a good quality, low cost Holter monitor, but it felt completely different to me than the burnout I experienced changing all these meds and everything else and the other prior authorizations I did, because I could directly benefit my patient. I was saving the patient money, I'm saving the employer money, and it directly benefited them. So there was this like aha moment that went on. And then the other beauty for me is that, yeah, as an independent provider, I get to work with the groups that are responsive to me, that are high quality, that are lower cost, that have bundled services so that I can say, you know what? Yeah, you don't have to go just to this system anymore. And I can send you here or there or wherever, whatever's convenient for you, whatever the lower cost is, whatever the higher quality is. And it's really interesting because this is more the free market model, right? So if I call one specialist group and they don't take my call and don't want to, work nicely with me, I'm not going to use them again. If I send somebody into a big system and they disappear, and then I don't want to use that system again either.
One piece that Wendy, you mentioned how much work you have to do. And that's what we don't want, right? We want the right people doing the right work. And some of the benefits consultants and some of the plans have care coordination and care navigation. That is key to this, I think, and finding the way to get to that point. We are happy to help. We are very happy. We want to help. We want to do the right thing for the patient. We want to know the patient's going to get great care. We want the patient to see the specialist and come back to us. I'm happy to help interpret. I'm happy to help manage the medicines from there. Tell me what to do in case there's a little problem. And if there's a big problem, I'll call you back. But we also need help knowing who those specialists are, especially in a state like Wisconsin with all these big systems, of knowing who's independent, who we can work with, how can we make it easy for the patient, also easy for the employer.
And also to save that specialty care for the patients who actually need the specialty care. So the specialists want to see the complex specialty care patients. I can do a ton. I've worked in rural family medicine, but there are limits. And so if I could just talk to a specialist and say, hey, do I need to do this with their meds? And the specialist is able to say, yep, just do that. I don't need to see them or whatever. We're saving the patient time, money, everything to keep them out of that specialist care for something that might just take a phone call with me and a specialist. And then when the patient actually needs something, much more complex, that's what the specialist wants to see anyway.
Do you see any barriers from systems or from other entities for the patients that are utilizing your services?
Yes.
And it's across the board,
what
right?
What a loaded question, right?
Yeah, exactly.
It's the same barriers in healthcare everywhere. And it's still access. It's still, cost. It's still time and money. We all understand that. I mentioned the care navigation. Surprisingly, it is interoperability too. I can't help those patients if I don't know what happened and what the specialist told them, or if they're going to the emergency room, what happened there. So that was a surprise to me coming from, a big healthcare system with a well-known EMR, switching to something smaller, trying to work with the other practices in the area and just finding out what's going on with the patient, again, because they are going to come back and have questions and concerns, and I want to be able to help with that.
And I think one of the biggest issues for me is that we have patients, and again, because Wisconsin is so like HMO, PPO heavy, is that we have, local large insurance company, other local large insurance company, and patients a lot of times, the employer contracts 1 year and they get the lower price from company A, and then the next year they get a lower price from company B. So then patients are always having to switch their primary care year after year. So they're not getting good continuity of primary care. But one of the situations I just ran into, and so I really don't want to refer to, system B anymore, is that I tried to refer a patient in for an MRI. She has a known aneurysm. She needed a follow-up MRI and to see a neurosurgeon. And I tried to refer back into the system as her direct primary care provider. And they said, no, she needs to establish with a primary care provider in that system before she can get her. And then that primary care provider has to write for the MRI and the referral to neurosurgery. And if we, and you know, I don't know how many of you employers, you know, are familiar with like the triple aim, the quadruple aim, the quintuple aim of medicine, where it's patient satisfaction and affordability, and then looking at provider satisfaction. That doesn't fit any of these things, you know, because your patient isn't getting the care that they need. They're going into a system where this MRI is going to cost them way more than what I could get them at a, you know, independent radiology group somewhere else. And then the poor provider, who this is a new patient to them, and I've known this patient for years already, is basically having to see them so that they can write a referral that I've already done, but it's been declined. And this, again, is just not good patient care.
So how do you deal with it? How do you work around this?
So I talk with my patient, and in some instances, my patients have to establish with a primary care provider in one of the systems so that they can get some of these referrals, because that's what their insurance says. In other instances, we talk through, well, with your copays and deductibles, it's actually going to come out. So there's a MRI case where before the deductibles and copay, we were told $6,700 from one of the systems for the MRI for the patient. With deductibles and copays, the patient would owe $2,100. Patient was willing to drive to an independent radiology center an hour away, and they got the same MRI with gadolinium injection with a board certified radiologist for $650. So sometimes the patient's like, okay, yeah, I'm going to, you know, forget about the whole insurance thing, and we're just going to go completely outside.
If I could add to that, what we do about it is you have supplied us with some helpful tools of where to send folks. And so when we do have a referral, we actually go to the high value panel that the Alliance has built, as well as the bundles that we're talking about. And when we need to have someone in a clinic, we've got folks for that as well. So it is collaboration, and I just can't tell you enough, you're overpaying. This is an incredibly expensive market. You are definitely overpaying.
The patient advocate in me, my like blood pressure is all right, pricing all the costs. Yeah, I think when we're talking about all of this, the patient is not at the center of care,
Yeah.
right? And so having a mindset where the patient is at the center of care, I think everybody in this room probably has that, but you know, we all need help. We're all patients. So having a patient advocate, a care coordinator that is part of your team is key, because we can't do it alone.
Yes, I agree.
Along with that, patients really want to be involved in their care. They want to feel that they are active in having successful results. And so getting them to the best care is one thing. Once they're there, how do they continue to navigate and be a good steward of their own care? One thing that Holista does is, I mentioned about kind of wrapping that envelope around the patient. I'm going to give a very concrete example about how we drive down cost and how we partner with the patients to be successful in their own care. It's very well known that one risk factor of having an infection during a surgical event is if you wash with Hibiclens or an antiseptic soap prior to surgery, that will decrease your risk of infection by nearly 50%. Easy, right? So what Holista does is we engage the patient 3 days prior to surgery saying, hey, Kate, you're 3 days from having your shoulder arthroscopy. Are you washing with Hibiclens? If the patient says yes, yay, Christ, poor outcome averted at that point. If they don't respond, or they say, yeah, I'm not going to do that, Holista takes the responsibility within the structure of our product to close that gap before that patient even enters that OR. And we tie that back to employers' incentive programs to say, hey, you understand that you're receiving a great benefit. This is what you need to do to remain compliant and not lose that benefit. So Holista has been able to take the clinical side of healthcare and the financial side of healthcare, that provider-patient relationship and the employee-employer relationship, and through a single product, bridge those gaps and reduce cost.
Can I mention one other thing on patient
Absolutely.
engagement? We know patient engagement is really huge, and it's has a very great impact on positive outcomes. So a lot of times we get questions with .com therapy because we provide speech therapy services and occupational therapy services in addition to behavioral health services. Well, how do we do that virtually, right? Especially in the pediatric space. Well, a lot of it is really through caregiver engagement, right? My son is 6 years old, and he has had speech therapy with .com. And, you know, part of me helping him is being there with him. So I don't drop him off into therapy and leave and go do errands. I'm actually sitting there with him. And so for us as a family, we do a lot of pull through then. So if he was stuttering or if he has trouble pronouncing, we can pick up cues that the provider, the therapist is doing, and we can help him. So the whole family is engaged. And I think it has made a great impact. And he's graduated from speech therapy. And now I have 2 other daughters who are interested in becoming therapists. So it's been a great experience. Yeah.
That's fantastic.
Yeah.
So I know we're very passionate, all 6 of us, right? 6 of us. We're very passionate about making this new ecosystem work, right? So Tom, I'm going to start with you. How do we make it work? How do we all work together? We were, in fact, just having this discussion even 2 minutes before we started this panel discussion. How do we put it all together? I'm going to start with you, Tom.
Yeah, that's a really good question. It does start with you. So I mentioned it casually, but and I mean it sincerely. You actually, if you're interested, can provide your contact information to your employees and offer a concierge service with care coordination, care navigation on a just-in-time basis. Anytime that they need that service, they can use it. You get paid or billed half of what you would be billed normally from any other provider in the marketplace. You get savings immediately, and they don't have to use it. They can use it. So you start by saying, I'm going to make these types of services available. If you can, and people are willing to make permanent decisions for DPC, that's even better. So those are some options that you can start with on your end, and then it moves to us. Operationally, we have to get the coordination working, and that's where I've said it, and I'm not just saying this because I'm on this panel, but the alliance is special. It has assets that no one else has. The information, our physicians, our care navigators, our nurses, all have access to the place you want us to send the patient for those types of services, and you heard it. $6,000 for something you can get for $800. I mean, that is just ridiculous, and you're paying for that.
600. That's right.
600. Oh, I overstated it.
To be exact.
So yeah, it's really a serious issue. And in this market, the only way around this is to strengthen the independence, and then we work to start to create that innovative location where other physicians then want to join it. There are some physicians recently leaving some big practices because they want to be in a better ecosystem as well. But now we have to get them the business so that they can succeed at it. The last thing we want to do is have the hospital systems use the funds to repurchase them. I think you may not know this, but physicians can't grow very easily because all of their income has to go through their personal tax before they can invest it. Hospitals can raise bonds or sell bonds and then use that money to buy practices. So they have this natural advantage, and it really should be turned upside down. Physician leadership is what will do it, and then coordinating operationally behind the scenes.
Wendy, do you want to go next on this question?
Yeah, so I think a lot of it is, using all of the different resources. I think a couple of things came to mind. So what we've heard about like the economy and stuff, it's a tough job market. So I'm seeing more and more small employees turn to me to be able to offer some kind of healthcare coverage, because a lot of times small employers don't offer anything. And when you're fighting for employees in this job market, you want to be able to offer something. So DPC offers a nice low cost option to at least get employees primary care. And then for the larger employees, the same thing. And one of the comments you had made as well is that a lot of the mistake people think of is that when you're with a big system, you get to choose your primary care provider. And that's not true, because most of their panels are full, or they're directing them only to certain providers. So even though you only get me at my clinic as your physician, that's not a lot different than if you were to go into a big system where they advertise 20 primary care physicians. Well, only one of them has an open panel anyway, so you can only actually see one of them. But then, yeah, a lot of it is starting to utilize the resources. And this is what I love about, this group and stuff is all of the different options that we have. And so, yeah, I use a lot of, I have physical therapists that will go out to homes to see patients. I have online mental health that I work with. I love, the bundled pricing, the independent specialists to work with. It's utilizing all of these, innovators, entrepreneurs, all of us crazy people who are outside the box to really kind of come up with what works for individuals, small businesses, large businesses, knowing that not one solution is going to be perfect for anybody. And so being a little flexible with a lot of that stuff as well.
Sabina?
So, changing the ecosystem won't be easy. We've all seen that. We've seen our wonderful people who won awards for doing this kind of change and just taking that first step. I think knowing that the care is still good, quality care, and that there are providers out there is one of the first steps, and that we're all trying to work together collaboratively. One of the pieces from the employer standpoint that I found fascinating and very helpful is just removing the barriers for their employees, for my patients. It's no cost to come see me. If you can do that, that takes a lot of stress away. It doesn't matter if it's virtual or if it's in person or if it's a phone call. And that phone call from their doctor, as Wendy said earlier, goes a long way. Instead of coming through a nurse and then the patient has more questions and then it goes back and forth and back and forth. We've all been in that situation too, which isn't good care. It's giving them the time off. It's in some cases giving the transportation voucher so you can get to the independent radiology group to get that test done. And then when I get the test result, I can, again, call the patient. No harm to me, no harm to them in terms of financial harm, manage that to get them to the best care. So small pieces start to add up, and eventually, hopefully, you get to the big piece where you can do all of the collaboration that you need to cover the full patient care needs.
And I think a good point there too is, again, as we're talking about, the current market, is that preventative care aspect of it, is that I can spend more time doing preventative care to try and keep patients out of hospitals, out of urgent cares, out of ERs, and at work. And I engage them to do that as well. So, if you're on my patient panel, I'm going to start calling you at the beginning of your birthday month to say, hey, we need to get in and have you seen, at least once a year here. And then, I'm going to be texting you, I'm going to be calling you, I'm going to be, trying to get you in. And at the same time, trying to meet you where you're at. So if you come in and you're like, yeah, I'm not doing that flu shot, not going to do it. Like, all right, well, let's talk about it. Why do you not want to do it? But I also have that time to sit there and have these conversations and then to engage patients. And over time, what I found, and I have one patient who just always comes to mind because, yeah, off the grid, completely out there, conspiracy theory, and now he got his COVID vaccine. And it's these relationships, it's the sitting down and talking to him, it's these long office visits that I get to spend with my patients. Another patient who was like, I really need to talk about anxiety, but I only have 30 minutes at lunch. I'm like, telehealth. You got a private office at work? Yeah, let's just jump on telehealth. You don't have to drive 15 minutes to the office. We can talk about this on telehealth. So having these different options available, I think, is huge.
So we could be talking here for hours. I'm fascinated with this conversation. With some of you, we've been doing it, right, for hours. But, I'm just curious, and I'm going to ask the same question to all of you. How can you do it, all of you, at an affordable price when others cannot? What is your secret? How do you do this? I'm going to start with you, Kate.
I'm going to say the number one reason is because we reduce variation. Variation in how care is provided, variation in cost, and it is predictable, and we are able to affect outcomes. And we have really great providers in our network that are providers because they don't want to be in the systems, because they want to do really great work for a fair price. And they are excited about the outcomes they can produce because they're no longer have their clinical care under what they call shackles, and that they can do the right thing for the patient for the right reasons. And so we have a very high performance network of providers and facilities that are partners with Holista. They lean in on our clinical care pathways. They know very much what are those critical pivot points in patient care to reduce risk. They are invested in those outcomes, and we affect total cost of care. So we have great partners, and also our technology is really brought a lot of efficiency. We provide a lot of service. We are a service organization, but because we have technology that keeps us very, very efficient, we can do it at a very fair price. We, compared to fee-for-service prices in the market, again, we're 55% less, and we have warranty and. So unit price 55%, the value adds are beyond that. So that's how we can do it. Great technology, great partners, and invested physicians.
And Bridget?
Yeah. So one of the ways is we really specialize. So we specialize in therapy in those 3 areas of speech, occupational therapy, and then behavioral health services. We also have 200 providers across the country. We have a 97% provider retention rate, which is pretty huge in the industry. So we really take care of our providers. And we look at our prices, and we want to be reasonable. We do not want to make this out of reach for families. Our tagline and our mission is therapy for everyone, everywhere. And so we're really committed to that. So part of our strategy actually is when we enter a state. Wisconsin is the first state that we have entered, and we're really marketing that. But we enroll with the state's Medicaid because we truly want to serve all patients and families.
That's fantastic. I did not know that.
Yeah.
That's fantastic. Thank you. Tom?
The way we can do it, we were founded as a company that supported a provider-owned HMO. They took capitated risk on Medicare Advantage members, and they needed to manage these chronically ill members at scale efficiently. So they built a technology platform behind the scenes that allowed virtual oversight and management. They then sold that service to providers. So providers actually use us to do their oversight for their patients. By the way, we can talk if you guys are interested. Some leverage. But that's one part of it. The second piece, though, is you may not know this, but 85% of all people in America only need primary care and medicine. That's it in a given year. It's really the vast majority of people need the primary care, but they're not getting it. In fact, I would challenge you. You probably do not know who on your workforce has their A1C under control, their hypertension under control. Sadly, your doctors, while the data is available, they have 10 of your patients and they have 7,000 other patients. They don't know either. So using data to identify that can help us get ahead of the game and get that hypertension controlled before it becomes chronic kidney disease, before it becomes ESRD. If you stop that journey, that's $1 million claim easily. So that's one piece of it. And then the other piece is 90% of what is done in primary care is all cognitive. The physical hands-on is less than you might think. So we don't have clinics. We don't have to pay for the oversight and staff of the clinic. We don't have to clean the clinic. We don't have to have janitors. It's very, very efficient. And as a national scaled company, we're able to serve throughout the entire country, doing the things that we can do before we hand it off.
Yeah, and absolutely, our advice to employers is we should pay more for primary care because that's not really where the spend is. The spend is in these services that we've been talking about with Kate and Bridget. But tell me your opinion, Wendy. How do you do this?
Keeping overhead low because I'm the janitor, which is true. So yeah, I actually started as a micro practice. And so I actually started out of a 1-room office suite with the exam table in one corner and my computer in another corner. And I was the receptionist and the medical assistant and the nurse and the janitor and the doctor and everything in between. I now moved into a larger clinic, but yeah, my 2 biggest expenses right now are my nurse and my rent. Other than that, as a direct primary care provider, I don't work with insurance, so I don't need coders, I don't need billers, I don't need contractors, I don't need any of these other staff to deal with any of that kind of stuff. I directly partner with vendors such as LabCorp and Quest for labs, so I can tell you right up front, your cholesterol panel is going to be $6.82, and I include a 10% markup on that to cover my supplies. And so being able to directly partner and not deal with insurance has been part of what has helped me, I think.
I would echo that. For direct primary care, it's reducing administrative burden. That's really what brings down our costs. We are cognitive. It is my training and my experience that the patients need and want. And so we, don't have I think, what did Tim say, 10 plus people in the back trying to help figure all this out and signing contracts and measuring metrics that patients don't understand, employers don't understand. I mean, we're trying to keep it to what's useful and meaningful. First to the patient, of course, we want to get the care, we want to give the buy-in, but also what is useful to the employers. So yes, we need data. We need, again, meaningful, useful data to help us with that. That's what we're learning as we go here. We are using APCs, other clinicians to help with that, but still having physician oversight. We know good APCs can always help us in care. It's part of a team model to have different extenders and people helping, but to always have that physician available because everybody still needs a primary care physician. We've talked about that many times here. So we want to echo that our model is slightly different, and we also have to have different ways of working and different models out there.
I've got to add though, what I think I heard was we're 60% below what you're paying everyone else. And I think you said you should pay us more. So thank you. We'll
Yes.
talk.
I just lost my job, didn't I? Can we bring up the lights to see if the audience has any questions, please? Whoever has control of these magic lights. What questions do you guys have at the audience, employers, brokers, etc.?
I have a question for Tom. I see ACOS MD has work comp services, with each state having different rules regulating that, and in particular Wisconsin not having maximum allowable payments. How are you disrupting that market?
Excuse me, I couldn't hear the maximum
Allowable payments.
Oh, for work. Oh, work. Okay, so work comp question. So this is a great question in work comp. So we also have a full work comp practice and can do the full employee regardless of medical versus work comp side. On the work comp side, you can't steer to providers. There is no incentive for your providers to negotiate with you. There are network discounts that are helpful, but they don't go very far. Bundles can go even further. But the problem is you can't get people there. If they go to the emergency room first, which is typically what happens, they hurt their wrist, they don't know if it's broken or not. A physician could assess that with good probability of assessing whether it was broken or strained, whether you should treat with pain relief and treat the swelling first before you go in. And many of these issues wouldn't be in an emergency room. But if you go to the emergency room, they work up a full panel, then they send you into that ortho path. Now you're trying to unwind that. So the way that we can help in that world is if you put a nurse triage service in front, or if that elevates to a physician, which is what we do, then at that point we can write an order to another physician. So we're suggesting to the employee, I can book you with this MRI in 5 days or 3 days, or you can go wherever you'd like. We can't force them to steer, but when a physician is making that recommendation and the order, it can have a big impact on that and get people to other locations of service. So there is quite a bit of savings available in the work comp. The smaller you are, the more difficult that is, of course. But if you're larger and you're experience rated, it can really help you.
I'll just add to that, we do have episodes of care for work comp here in Wisconsin. Our value-based healthcare contracts in our network do include work comp at the exact same reimbursement. So we've been able to get some traction there as well.
And I think Wendy was about to say, we also encourage our patients to call us in those situations too, or the employer does. So to work with direct primary care, because we can do the same thing. We can work with whoever may be more effective and provide that high quality care that the employer has determined or their network has determined.
Yeah. One of my employers is a veterinarian clinic, and so a patient got a cat bite on the hand. These tend to become infected. They need to be evaluated, treated, given antibiotics. So they sent them over to my clinic at 5 o'clock on a Friday night, and I was able to meet the patient there, do the entire visit, and send them out the door with their prescription for $1.82 worth of antibiotics. And the patient loved this because they weren't sitting in an urgent care forever. They also didn't have to go to a pharmacy to pick up their prescription because I was able to dispense it from my clinic. So, and then the cost for the employer in terms of that work comp episode was, they're already paying their $70 a month fee for my primary care. And so they just owed, $1.82.
Other questions?
Absolute advocate of everything that you're doing on the medical side and the 60% savings and all that. of the self-insured healthcare dollar, that's going to be a big component, the home medical side. Can you apply a lot of the same principles to the pharmacy side, which works out to be about 25% of that healthcare dollar? There's as much collusion, spread pricing, supply chain issues, lack of outsourcing offshore or whatever, with a lot of gains to be had on that side as well. I don't know if you wanted to, that could open up another whole half-hour discussion, I
Oh, for
realize,
sure.
but didn't know if you wanted to touch on that at all.
No, I'm
You-
happy you do, Gordon. Thank you. Yeah, please.
So in Wisconsin, it's kind of nice because as a direct primary care physician, I can dispense from my clinic. So I work with wholesalers for medications and do a lot of generic medications from my clinic. So if you need your blood pressure medicine, your thyroid medicine, your cholesterol medicine, your diabetes medicine, your antibiotics, those are in clinic. And basically, again, I have a 10% markup on those. So your 90-day supply of your levothyroxine for your thyroid condition is $3.91. Your 90-day supply of amlodipine for your blood pressure is $1.89. Those all include my 10% markup for my vials and supplies and so forth. And then from the patient perspective, I had one guy tell me this the other day as he was walking out with his prescription. He's like, not going to the pharmacy? Priceless. But then the other thing that I commonly do is work with community pharmacies as
Right.
opposed to big chain stores, because the community pharmacies are really willing to work with my patients to try and get them the absolute best costs, to try and bring down those costs wherever possible. So controlled substances, I'll have to go through a pharmacy. Specialty meds, I'll go through the pharmacy, but most of the generic ones I can do through my clinic.
Yeah, I
The
was
money is
actually
in the special
bargaining the
pharma.
price with the pharmacy that you're using because I'm in an expensive medication, as you know, but I was bargaining. I'm like, so will you give me $200 off of that? They did. They did.
Yeah.
They were absolutely amazing. They did. I didn't mean to interrupt. So I'm so
Yeah.
No,
sorry.
I was just going to say, specialty pharma is a major issue. There was something like 15 new chronic conditions medicines that came out this year that were approved by the FDA, and they averaged over $100,000 a year per medication. So that's the new world, and it's a really big issue. And if you try to wrestle that away from your payer, ask why they're fighting so hard to keep it. This is a very ugly part of the business, and the money is really real. But again, there are assets that you may not be aware of. We do location, we shift the location of service for specialty pharma. Since if you're doing a injection, if the injection's done at a hospital setting, you might be paying $20,000 for something that you can get for $1,000 if it's done at home with someone else delivering it. So there's a lot of creativity in that area. It's a whole, as you said, Gordon, it's a whole area of, we could spend a day on this one, that topic.
One thing to add to that, a huge enhancement 2023 with Holista is any medications associated with your episode of care will be included in the price just as any other service inclusion. So that will not be flowing through the pharmacy benefit. It'll be flowing through the episode and at a fixed price. So it's included just like any other service line. It's a supply as far as we're concerned.
You know, that is one thing you may not be aware of either. If you partner with a provider to share data, we take data and we analyze claim data for care gap, but we also can analyze it for location of service, for types of medications, for savings in medications. You heard it. Yeah, again, you may probably know this, but if you go to a clinic and get your blood drawn, they send it to Quest and Lab too.
Right.
They pay the $5 and they charge you the $105. And that's just the way it works. And so you can get that directly by engaging a company doctor. That's the approach we take. You get one company doctor and they would do some oversight of that.
Thank you all. This was so amazing. I hope we can do this again. And I know I look forward and the Alliance looks forward to working with you. And I didn't even have to call the boss. The boss is up to wrap us up. Thank you for the time.
Thank you so much. Weren't they fabulous? I just want to say, I think that we have strong allies in these folks and in others like them who are growing in number. It's so encouraging. So we're at the end of our session. A couple closing comments or notes regarding CE credits. If you'll be claiming continuing education credits for SHRM, HCRI, or for the brokers in the room through the Wisconsin Office of the Commissioner of Insurance, please be sure to visit the registration desk on your way out to sign out. Brokers, you need to sign an affidavit of attendance. I don't know what that is, but it's apparently extremely important that we have a record of your participation. There's also a handout available at the registration with specific SHRM instructions for how to claim SHRM credits. And for those attending virtually, please download the affidavit of attendance, et cetera, from the handout section of the webinar and get that back to us by Friday, please. CE certificates will be emailed out toward the end of the week. So upcoming events. Be sure to save the date for our next hybrid event, our spring symposium on May 17th. It'll be right here at Monona Terrace and also online. And if you like what you saw today, please consider bringing a friend. As Mike, I loved Mike saying, you're all on the membership committee. Yeah, there's strength in numbers, and we're always looking to grow. So for those of you here with us in the room, please remember that there's a networking cocktail reception right out on the Grand Terrace just down the hall. And it'll be a great opportunity to catch up and continue the conversation in a more relaxed format. Also, for those of you that took the opportunity to complete this sign-up sheet to be added to this letter, you can leave those at the registration desk as well. We look forward to getting your feedback on this session. As we mentioned at the outset, it's a different format for us, and we're interested in your feedback and ideas for improvement. Thank you again for your membership in the Alliance and for your support of our organization and our mission. And I hope you all have a safe and happy night.